Good day and thank you for joining me. Today we will explore a critical and often overlooked connection, the link between chronic kidney disease, heart failure, and liver dysfunction, especially in the context of obesity and diabetes. These conditions don't exist in isolation. They form a complex interdependent syndrome driven by metabolic disturbances. In this session, we'll unpack how metabolic syndrome sets the stage for multi-organ damage, how each organ's dysfunction reinforces the others, and why understanding this interplay is essential for effective prevention and treatment. So let's dive into the cardio-renal hepatic axis and the adverse consequences of metabolic disorders. Now let's briefly examine obesity and diabetes as a global health challenges. The graph illustrates how rising body weight correlates with an increased incidence of type 2 diabetes. In essence, the growing prevalence of type 2 diabetes over a period of time aligns with the rise in obesity, emphasizing their strong link known as diabesity. The obesity-driven disease triad, obesity drives cardiovascular disease, diabetes, and kidney disease through common pathways such as inflammation and insulin resistance, forming a harmful cycle that necessitates a comprehensive treatment approach. The link between obesity and type 2 diabetes extends beyond a simple correlation. It is driven by complex biological mechanisms. Key factors include elevated non-esterified fatty acid, which infiltrate vital organs, triggering chronic inflammation, oxidative stress, adipokines imbalance, and lipotoxicity. This disruption impair insulin sensitivity and beta cell function, leading to type 2 DM, reinforcing the cycle of disease progression. Addressing this cycle requires a comprehensive approach, combining lifestyle modification, pharmacotherapy, and targeted intervention. These slides illustrate the traditional classification of cardiorenal syndrome or CRS, which highlights the complex and bidirectional relationship between the heart and kidneys. CRS is divided into 5 distinct types based on whether the dysfunction is acute or chronic and which organ is primarily affected. We begin with acute cardiorenal syndrome. Type 1 occurs when an acute heart injury, such as sudden heart failure, leads to acute kidney injury. Type 3 conversely starts with acute kidney injury that triggers acute cardiac complications. Next, we move to chronic cardiorenal syndrome. Type 2 describes chronic heart failure progressively impairing kidney function, resulting in chronic kidney disease. Type 4 is the reverse. Chronic kidney disease contributes to the development or worsening of chronic heart failure. And finally, type 5 refers to a systemic disorder such as in acute one, sepsis, other critical illnesses, or in chronic diseases like diabetes that impacts both heart and the kidneys at the same time. The diagram emphasizes the bidirectional nature of this interaction, with arrows indicating how dysfunction in one organ can precipitate or exacerbate dysfunction in the other. This paradigm shift from viewing the heart and kidneys in isolation to recognizing their interdependence has profound implications for diagnosis, treatment, and prognosis in clinical practice. Now, this article proposes a new framework recognizing the deep connection between cardiometabolic disease, once seen as a separate condition like obesity, type 2 DM, and heart, kidney, and liver disease, are now understood as interrelated, emphasizing the need for a more integrated approach to their management. Now, before that, in 2023, the American Heart Association introduced CKM syndrome to emphasize the interplay between heart, kidney, and metabolic factors. Notably, the liver was excluded despite its central role in metabolic dysfunction. Conditions such as muscle D or metabolic dysfunction associated steatotic liver disease and MAS, metabolic dysfunction associated steatohepatitis, which are closely linked to insulin resistance and obesity also exert significant effect on cardiovascular and renal health. So, expanding from cardiovascular kidney metabolic models to a broader cardiovascular renal hepatic metabolic syndrome underscore the need for a more integrated approach to diagnose and treatment addressing the complex interplay of these interconnected conditions. This schematic diagram depicts the pathophysiological progression of cardiometabolic syndrome starting from adiposity as the first stage of CRHM, stage 1 as preclinical obesity. Dysfunctional or excessive fat tissue disrupt the heart, kidney, and liver, leading to progressive dysfunction across these organs and ultimately culminating in cardiovascular disease at stage 4, clinical obesity. Now, this is why obesity is the central component of this complex metabolic disorder. Now, to highlight the impact of metabolic syndrome on cardiorenal and hepatic disorder, diabetes and obesity, often termed diabesity, play a key role in their progression. These conditions share underlying pathophysiological mechanisms including hyperglycemia, hypertension, dyslipidemia, excess weight, forming a recognized cluster of risk factors known as metabolic syndrome. Now let's talk about metabesity. Now, Dr. G. Alexander Fleming coined the term metabesity and organized the first Congress on metabesity in October 2017 in London. He coined the term metabesity to describe the connection between cancer, heart disease, neurological disorder, diabetes, and aging, all linked by shared metabolic causes and potential preventive treatment. Currently, metabesity describes a strong link between obesity and metabolic, and its highlight obesity as the key contributor to metabolic dysfunction, sharing underlying mechanisms such as inflammation, hormonal imbalances, and insulin resistance. Metabesity arises from interlinked causes, including genetic predisposition, lifestyle factors like poor diet and inactivity, and environmental triggers. Chronic inflammation, hormonal imbalances, and epigenetic changes further contributes, creating a cycle of metabolic dysfunction. Addressing these factors is vital for effective prevention and management. A summary of the pathophysiologic link between obesity and metabolic syndrome and diabetes. Excess visceral fat drives insulin resistance, inflammation, and metabolic disruption, heightening the risk of metabolic syndrome and type 2DM. A cluster of metabolic abnormalities with insulin resistance at its core fuel CVD and diabetes. Persistent insulin resistance from obesity and metabolic syndrome leads to hyperglycemia and vascular complication. These interconnected conditions not only amplify each other but also increase susceptibility to heart disease, kidney dysfunction, and liver disorder like muscle D. This illustrates the role of immunity and inflammation in obesity. The excess lipid accumulation triggers widespread inflammation affecting key organs like the liver, pancreas, adipose tissue, skeletal muscles, as well as the brain. Additionally, obesity alters immune balance by enhancing type 1 immunity, which increases pro-inflammatory activity and suppresses type 2 immunity, which is an anti-inflammatory activity. This disruption contributes to tissue dysfunction and insulin resistance, fueling metabolic complications. The latest IDF Global Clinical Practice Guideline for managing type 2 diabetes includes a dedicated chapter on cardiorenal protection, recognizing its vital role in addressing the high rates of early mortality and serious health complication among individuals with type 2 DM and obesity. On the right, diabetes-related complication now features muscle D alongside with neuroretinopathy. Now, when we look at CVD and muscle D, again, we see the same risk factors: central obesity, metabolic syndrome, type 2 DM, hypertension, dyslipidemia, and CKD. Moreover, muscle D is associated with an increase in the risk of development of chronic kidney disease, cardiovascular disease, as well as type 2 diabetes. So, unmanaged metabolic associated steatohepatitis or MAS can lead to a serious health complication. It may progress to liver disease including cirrhosis and liver failure. There's also an increased risk in CVD as well as liver cancer. So early diagnosis and treatment are crucial to prevent these outcomes. So muscle D is highly prevalent regardless of diabetes status and is often asymptomatic, earning the label silent liver disease due to its unnoticed progression, especially in early stages. Patients with 2 or more cardiometabolic risk factors should be screened for muscle D to enable early detection and intervention. So in high-risk individuals, we can screen patients by calculating FIB-4 score or using the FIB-4 applications. The FIB-4 index is a simple, non-invasive method that estimates liver fibrosis based on age, AST, ALT, and platelet count. A score under 1.3 indicate low risk manageable in primary care. Values above 2.67 suggest advanced fibrosis requiring specialist referral, and intermediate result call for further evaluations. Now here you can see an algorithm guide the clinician in assessing cirrhosis risk among muscle D patients, especially those with diabetes, prediabetes, or obesity, plus cardiovascular risk. It starts by ruling out secondary causes, then use the FIB-4 score and liver stiffness measurement to stratify risk. Low-risk patient with FIB-4 less than 1.3 or imaging through liver stiffness measurement of less than 8 kilopascal are managed in primary care with lifestyle support and periodic reassessment. High-risk patient with a FIB-4 of equal and above 2.67 or a liver stiffness measurement of equal or more than 8 kilopascal requires specialist referral, further imaging, and long-term follow-up. This approach helps prevent cirrhosis through early detection and tailored management. So the underdiagnosis and undertreatment of muscle D, it's a growing healthcare gap. Metabolic dysfunction associated steatotic liver disease remains widely underdiagnosed and undertreated despite its high prevalence because fewer than 30% of patients present with elevated liver transaminases. Diagnosis often require imaging. In addition, effective medications are underused, referral to liver specialists are limited, and the absence of standardized diagnostic protocol further contributes to the underestimated prevalence and inadequate treatment. Now, this study reveals that MAS or metabolic dysfunction associated steatohepatitis is often underdiagnosed, managed inconsistently across regions, and treated with limited approved options, underscoring the need for stronger guideline adherence to improve outcomes. Now, let me shift my talk on CKD and its recognition. The recent study or survey that there is a low rate of CKD awareness and detection in the current era, in spite of screening tools such as serum creatinine and UACR are easy, accessible, and inexpensive. Perhaps most patients are asymptomatic, especially early in the course of CKD, so we need to look for them. Ambulatory heart failure in type 2 DM are slowly progressive and many are asymptomatic, especially if the heart failure is diastolic. Here, In one of Indian study have shown majority of asymptomatic heart failure have subclinical heart failure results on resting echocardiogram. So what's the impact of cardiorenal metabolic in patients with diabetes? And the answer is reduction in the life expectancy. For example, among individual age 60, those without diabetes may live 20 or more additional years. Simply adding a diagnosis of diabetes can cut life expectancy by about six years. If we then add another complication such as early kidney disease, then that will reduce the life expectancy by over 9 years. And if we have a patient who developed cardiovascular complications such as myocardial infarction or stroke, then this would reduce the life expectancy by 11 years. Very powerful and important causes of premature mortality. So the important question is, are our treatment strategies that we are currently instituting on people with diabetes are really effective at reducing the risk of developing those complications? And if not, how might we change our treatment strategy to help reduce those complications further in the future? Now, this slide emphasizes a comprehensive approach to managing cardiovascular, renal, hepatic, metabolic syndrome, integrating multidisciplinary care with lifestyle adjustment. It underscores the importance of collaboration among specialists, lifestyle modification, and pharmacological treatment addressing multiple facets of the condition. Regular monitoring and patient education play a vital role in enhancing adherence and improving outcomes by targeting the root causes rather than just the symptoms. So, managing cardiorenal hepatic complication in diabetes calls for a multidisciplinary approach with specialists such as diabetologists, nephrologists, and hepatologists addressing the respective organ system affected. At the core of this team, the primary care physicians should play a central, empowered role coordinating care across specialists to ensure integrated patient-centered management. Or perhaps better, we can involve more as multidisciplinary care like nutritionists, diabetes educators, social workers, and etc. Now, the guideline-directed management incorporates three key drug classes that when used together effectively slow diabetic kidney disease progression and reduce heart failure hospitalization. Okay. RAS blockers, SGLT2 inhibitor, and non-steroidal MRA. These combined with early therapeutic lifestyle changes, these evidence-based strategies provide optimal disease management and have recently been integrated into official treatment guidelines. Despite clear guidelines, real-world practice often falls short. Evidence shows gaps in the use of proven therapies among insured U.S. patients with type 2 DM and ASCVD, as highlighted in the Journal of American Heart Association in this study. So in this study, it focused directly on physician prescribing patterns, examining how often patients were given guideline-recommended therapies for cardiorenal metabolic condition, especially statins, SGLT2 inhibitors, or GLP-1 RAs. It revealed that only a very small proportion, just 2.7%, receive all three recommended treatment, that is at the baseline of the bar in light green. Another study is the captured study conducted across 13 countries that assess the prevalence of cardiovascular disease in adults with diabetes. It found that about 1 in 3 participants had CVD, with arteriosclerotic CVD being the most common, And despite this, only a minority were receiving glucose-lowering treatment with cardiovascular benefit, highlighting a gap between guideline recommendation and real-world practice. The findings underscore the need for improved treatment strategies to address CVD risk in diabetes management. And again, another real-world study of about 537,000 veterans with ASCVD and type 2 diabetes across 130 veterans facilities examined real-world use of SGLT2 inhibitors and GLP-1 receptor agonists, and despite strong evidence of cardiovascular benefit, these therapies remain markedly underutilized in high-risk patients. In summary, cardiorenal liver disorder is a major complication associated with obesity, metabolic syndrome, and type 2 diabetes. CKD and heart failure are among the most frequent manifestations, with metabolic associated steatotic liver disease further worsening prognosis. Diabetes and metabolic syndrome heighten the risk for cardiovascular disease and chronic kidney disease, making early detection crucial for timely intervention and better outcomes. Due to the complex interplay of cardiorenal and hepatic dysfunction in diabetes and metabolic syndrome, a multidisciplinary care approach is crucial for effective and holistic disease management. SGLT2 inhibitors and GLP-1 receptor agonists show promise in addressing the full spectrum of cardiorenal liver syndrome, including muscle D. Despite existing guidelines, real-world studies reveal a significant gap in their application, with these therapeutic approaches frequently underused in clinical setting. And with that, I would like to end my presentation, and again, thank you for listening.